Hello everyone. Today we are presenting a challenging case of MRKH syndrome managed with laparoscopic Davidoff vaginoplasty. This is the pre-op picture of our patient showing no vaginal canal at all. Our patient had previously undergone two perineal vaginoplasties at another center. But unfortunately, both procedures had failed and she presented to us with absence of a functional vaginal canal, making this a complex revision surgery. We began with laparoscopic assessment of the pelvis. An important finding was the presence of right pelvic kidney, which is a known associated anomaly with MRKS syndrome. We moved the bowel upwards so as to empty the pelvis and create enough space for our dissection. As we can see, the rectosigmoid is fully loaded with fecal matter. This shows the importance of bowel preparation before surgery. Now, another important finding to note was the absence of identifiable uterine ridge, making anatomical orientation more challenging. We then proceeded with the creation of neovaginal tunnel. Here we are doing that. So, as you can see, we are taking smaller bites and doing slow meticulous dissection. This is very important in laparoscopy as big bites lead to bigger mistakes, as our seniors tell us. Using combined laparoscopic and perineal dissection, we were trying to create an adequate space for our new vaginal tunnel. Here you can see how carefully we are doing that. Now we are separating the bladder so as to avoid injury to it. Here you can see using careful, sharp and blunt dissection, we tried to create a correct plane while safeguarding the bladder and rectum. Now once an adequate tunnel was created, we used serial Hagar dilators sequentially to gradually dilate the canal until an adequate vaginal caliber was achieved. Now we'll see the first Hagar dilator coming into picture. This is the first one. Likewise, sequential serial dilators were used to achieve an adequate width of the new vaginal tunnel that we have created. The depth was adequate. After this, the next step is to take stay sutures. So, next thing, we took four stay sutures at the four quadrants of the apex of the new vaginal tunnel. Here you can see first suture we took and then brought the needle out. Likewise, we did we repeated this step on the other three corners, as you can see here. All these four sutures were brought out through the vaginal introitus and anchored to the vaginal skin, providing traction and facilitating the next step of the reconstruction. Here we can see we have pulled them out. Is the pelvic peritoneum, including the peritoneum over the rectosigmoid, was then mobilized laparoscopically and brought to the apex of the new vagina. It was then circumferentially sutured to create a well vascularized peritoneal lining of the newly created vaginal canal. Unfortunately, we don't have a video of that. Now, after completion, we are putting a mold into the newly formed vagina so as to prevent post-operative stenosis. Now, this is the follow-up video. We can see the new vagina admitted one finger completely, comfortably. The patient was doing well and was happy with the outcome.